Hello, everyone, and welcome to today's webinar. I am Amin Yazdani, Director of Canadian Institute for Safety, Wellness, and Performance at Conestoga College's School of Business and the host for today's webinar. Today, we will discuss strategies to address operational stress injuries among Canadian paramedics. Our speaker today, Mr. Bronson Du, will be using disease prevention model to present prevention strategies based on the findings of a research and development study funded by Defense Research Development Canada. The key findings of this project were used to inform the development of a national standard on disability management system for paramedics. Bronson Du is a research scientist at the Canadian Institute for Safety, Wellness, and Performance. He has expertise in developing organizational level guidelines and resources for the prevention and management of work disability. He applies a system approach for data collection, analysis, interpretation, and reporting to inform the development of workplace interventions. Mr. Du has extensive experience in coordinating large-scale applied research projects and holds a Master of Science in Public Health and Health Systems and Bachelor of Science in Kinesiology, both from University of Waterloo. Before I hand over to Bronson, I would like to thank our audience today for their interest in our webinar series. If you have any questions, please use the QA function of Zoom platform to ask your questions, and I will get to those questions at the end of the webinar. Well, let's begin today's webinar. Bronson, floor is yours.
Thanks, Dr. Yazdani, and good afternoon. I'm very excited to be here today to speak with you about some of the research that we've been doing here at CISWP for the past couple of years to support paramedic services in preventing and managing operational stress injuries. In today's webinar, I'll be presenting a model for addressing operational stress injuries, or OSI, amongst paramedics based on research findings from key informant interviews and an environmental scan. So on the agenda for today, I'll first provide some background information as to the importance of addressing OSI in the workplace. Next, I'll talk a little bit about each of the studies to provide some context as to where the data is coming from. And then we'll get to the core discussion about the existing and desired organizational-wide elements, as well as some implementation tips for the primary prevention, early detection and intervention, and disability management of OSI. And lastly, we'll finish off with where we're headed with these projects and how you can still contribute to them if you'd like to provide any feedback or comments. So to start, let's talk a little bit about the roles of paramedics. Paramedics are heroes. They do a lot of altruistic things to keep the public safe. Right now, they're in the front lines combating the COVID-19 pandemic and putting themselves in close contact and at risk to help those with known and suspected COVID-19. And this is all done in undetermined and uncontrolled environments. So that could be in parks, in homes, workplaces, etc. Now, just very generally, the primary function or the primary duties, but not exclusive, of paramedic work is to provide out-of-hospital emergency medical care. And so this really is working at the intersect of emergency response, similar to police and firefighters, where they have to respond to 911 calls, and at like healthcare professionals, as well as they provide medical care to patients. Now, tending to medical calls can be stimulating and manageable sometimes, while other times it can be frustratingly non-urgent or strenuous and distressing. Some other characteristics of the work that's often associated with the work are long hours, shift work, and being on call. And so there's a lot of occupational stressors to the job, but it can also be very fulfilling and rewarding as well. Unfortunately, paramedics are a high-risk occupational group for a range of mental health problems, including both clinically and non-clinically diagnosable, so subclinical conditions that interfere with daily functioning. And so in this presentation, we refer to these either as post-traumatic stress injuries or PTSI, or operational stress injuries or OSI. And those terms, for the purpose of this presentation, we've used those terms interchangeably. As mentioned, paramedics are a high-risk occupational group for OSI. And so presented in this table are two studies. On the left column is a Canada-wide national survey of public safety personnel's mental disorder symptoms, and among other things. So this was a large study that collected a lot of data, and this was led by Dr. Carlton and colleagues. The data presented in the right column is based on a meta-analysis on the prevalence of PTSD and common mental disorders amongst ambulance personnel worldwide. And they included 18 studies there. And although the values in these two studies should not be compared due to different surveying techniques and methods, we can look at trends within the study. So just to note, among the Canadian paramedics, there is an alarming 49% of paramedics who did screen positive for at least one mental disorder in the self-reported survey. Another thing that I wanted to mention is that, interestingly, the prevalence of depression was greater than PTSD in both studies. And this kind of goes against conventional assumption that PTSD is the main OSI to focus on. But really what this means is that services need to ensure that their programs should also assist the identification, training, and support to address other forms of OSI, in addition to the traditional trauma-based focus. So OSIs not only have a devastating impact on individuals dealing with it, but also on their communities. So their friends, families, coworkers, their work capacity, and the organization's ability to provide responsive and quality care as well. So what can be done to prevent and manage OSI? Well, we know that responding to potentially traumatic events are unavoidable, but increasingly, there's evidence to support that operational and organizational factors can be modified to better prevent and manage OSI amongst paramedics. And so this one study from Australia, they found that manager psychosocial climate and manager support accounted for up to 13% of ambulance personnel's mental health and well-being. Now, 13% might not seem like a lot, but when we take into the consideration the non-modifiable factors such as genetics, environmental factors, personality traits, stressful life events, 13% actually becomes quite significant. And that large Canadian survey conducted by Dr. Carlton and colleagues, they also found that leadership style, organizational engagement, stigma, sleep, and social environment played a role, was associated or predictors of screening positive for mental disorders. They also found that participation in mental health training was associated with lower rates of positively screened mental disorders overall. So the workplace can play quite a significant role, quite a large role in addressing OSI, but it can also be the source of it as well. So with that in mind, we conducted 2 studies that focuses on collecting data to inform the development of guidelines and standards as to what organizations can do to prevent and manage OSI in the workplace. So we didn't focus as much on what paramedics can do for their mental health in terms of coping strategies or the clinical side of things, such as diagnosis and treatment of mental disorders by mental health professionals. But we really focused on the organizational role. So one of the studies that we conducted was key informant interviews, and the objective was to explore key informants' perspectives on the existing and desired organizational-wide initiatives for, as well as the challenges and potential solutions to the primary prevention, early detection and intervention, and disability management of PTSI in Canadian paramedic services. And so we interviewed paramedics, supervisors, and union representatives on topics such as policies, programs, and practices that would help prevent PTSI and maintain good mental health amongst paramedics, initiatives to help paramedics feel supported after potentially traumatic calls, things to help paramedics feel comfortable to talk about potential challenges with mental health, and initiatives to promote recovery of PTSI and ensure that symptoms don't get exacerbated. So in total, our interviews range from 68 to 148 minutes, so just under 2.5 hours, averaging about just over an hour and a half, 95 minutes. The interviews were transcribed and then thematically analyzed. And for the environmental scan, that was the other study that we've conducted. And the objective of that was to identify recommended organizational programs and practices for the prevention and management of PTSI in paramedic services. And to do that, we've conducted a web-based search and applied some snowballing techniques. So we searched websites like, but not exclusive to, Paramedics Chiefs of Canada, Paramedics Association of Canada, provincial paramedic associations, provincial workers' compensation boards, government websites, health and safety associations. So things like the the Center for Addictions and Mental Health, Canadian Mental Health Association, Public Services Health and Safety Association, the Institute for Work and Health, and the Mental Health Commission of Canada. So there really weren't many publicly available resources for addressing PTSI amongst paramedics in Canada. So we supplemented the search with international resources that went beyond the scope of paramedic work and PTSI. So these additional search, the results, this wasn't an exhaustive search, but this was all these additional results were used as supplemental material. We also consulted with a knowledge expert in work disability management for any additional resources and to ensure that we weren't missing anything vital. And so from each of these documents, we extracted the general information, the scope of the resource, and initiatives, programs, policies, or practices for the primary prevention, early detection and intervention, and disability management of PTSI. And any initiatives that we have identified, we also documented the value of the initiative, any good or recommended practices suggested in the documents, any examples that of workplaces implementing these initiatives, any barriers to implementation, as well as any additional considerations that we should be aware of. So that's the environmental scan. Now, for the purpose of the core discussion today, I wanted to go over a synthesis of our study findings, organized based on an adapted version of this disease prevention model for intervention, since it's a widely used and pretty well accepted model. In fact, in 2007, Christine Reynold and Dr. Shannon Wagner from Northern British Columbia University proposed the need to use this model as a multidimensional approach for stress management amongst first responders. And so this model applies to all types of diseases or illnesses, but they suggested that there was a need to apply it for the stress management of first responders. So at the core of this model, it features 3 levels of interventions. Primary prevention, which is aimed at maintaining good health amongst individuals of all stages along the health continuum, with a main focus on healthy individuals. Early detection and intervention, those types of interventions help to identify and support individuals with early signs and symptoms of a disease or injury. And then disability management, which I've broken down into 2. Those approaches aim to support the recovery from a work debilitating illness or injury, or when or if the illness becomes manageable, their work reintegration. So we have applied our findings into this model. And then in the next set of slides, I'll talk a little bit about the desired organizational elements identified by our key informants for each stage of intervention, and provide some implementation tips on the programs, policies, and practices that was identified through the environmental scan. So starting with primary prevention. So in the context of primary prevention or of OSI, there are initiatives or programs that employers could implement to reduce the risk of or prevent OSI and promote a psychologically safe and healthy workplace. So when we asked interviewees about organizational initiatives that would support this, our interviewees consistently suggested that having a psychologically safe and healthy workplace, having consistent supervisor support, mental health training and awareness, and opportunities for recovery and maintaining resiliency, those were vital for primary prevention. All right, so let's start with having a psychologically safe and healthy work culture. So this was a recurring facilitator for dialogue surrounding stressors, mental health, and support-seeking behaviors. In fact, it was an overarching theme that both impacted and was impacted by all the other organizational initiatives that we've identified. And interviewees agreed with that. Without a supportive work culture, mental health initiatives would not function as intended. And this was really emphasized by one of the interviewees. They said, you can have all the policies, programs, and practices in place, but unless people feel that the organization lives and breathes those policies and practices, they will always be reluctant to report their PTSI challenges. The overall organization in its day-to-day functioning needs to reflect the stated goals of the organization. So a lot of the elements and initiatives that I'll talk about will ultimately contribute to improving work culture, but there's a couple things specifically related to stigma that I want to highlight. Three conceptualizations of OSI emerged that was fundamental to improving work culture. The first one was OSI are legitimate injuries and may require medical support like any other type of injury. To this point, all interviewees shared similar insight that the stigma surrounding mental disorders has significantly decreased over the years. However, there's still some of those remnants of the old push it down, suck it up at buttercup and move on types of attitudes. And one of our paramedics expressed how such attitudes within the organization affected self-reporting. So one of the quotes they mentioned, people are still afraid to reach out and ask for help because they're scared of the stigma and scared of not even being taken seriously. So to address this, some of our key informants have indicated that their organizations have shown recognition for the legitimacy of OSI through programs and policies such as providing mandatory mental health training for paramedics. Our supervisor interviewees also mentioned that they personally try to ensure that all reports of OSI are taken seriously and that supports are offered while discouraging and limiting stigmatizing remarks. The other point was regarding to stigma was OSI are a normal outcome of acute and chronic stress exposures to stress. And this sounds pretty straightforward, but to operationalize, it was quite a challenge. All of our interviewees, they acknowledged that exposure to stress may result in OSI. But paradoxically, there was also a unanimous understanding that paramedic work requires elevated mental resiliency to deal with the elevated stressors of the work. And even though paramedics are a very resilient group, these conflicting ideas created a sense of being unfit for the job or weak when facing challenges or difficulties coping or rebounding. So organizations have identified that this issue exists, but face challenges in defining the thresholds and determining whether an individual is a good fit for the job. So paramedic supervisor stated, you, the paramedic, you know the profession you're getting into, you know what you're most likely going to come across. It's hard to draw the line as to whether or not you're suited for the profession. And so this underlying idea that paramedics need to be resilient to trauma because it's part of their job was a recurring reason for underreporting. Now, the third point was mental health services should be used proactively for monitoring and preventing OSI, as well as for diagnosis and treatment. So traditionally, mental health services have been used reactively or as a last resort for treatment rather than proactively to monitor mental health. And this notion of using mental health services reactively creates an underlying stigma or a concern of being judged or being treated differently for engaging with such services. However, these views are changing, and many of our interviewees suggested that mental health supports should actually be used proactively. And this quote demonstrates it pretty well. The way I look at it now, and I tell my colleagues, it's actually good to check in with a psychologist. So having built that report when you don't have any issues, so that when you do have an issue, you have someone that you already feel comfortable speaking with. It's like having a family doctor, like just to check in once in a while. So kind of normalizing the use of mental health supports as a preventative measure may help to reduce the stigma of seeking support later on. All right, so some implementation tips for supporting a psychologically safe and healthy work culture. Step one is make a policy statement. Define what your workplace culture should be instead of letting it happen organically, because setting those intentions, setting those value and that commitment, having that explicit policy and the commitment to address OSI, it makes it easier to bring that to the discussion table and really integrate it into decision-making processes. And so setting those intentions can be very powerful. But again, having a policy is only the first step. and the organization will need to follow through with actions to live out the statement. Another point was to promote mental health initiative. So endorse and participate in mental health campaigns and promotional activities. So a good example is participation in the Bell Let's Talk Day. Support workers in engaging in daily practices that promote mental health and well-being, and provide regular updates as to what the organization is doing to reduce stigma and raise awareness. Lastly, I just wanted to add this point in there to ensure that confidentiality and privacy rights should always be respected and protected. All right, so that's the first point. We'll move on to the second point, the second key element or desired element for primary prevention. And this is consistent supervisor support. And so paramedics express their desire for consistent supervisor support, often by comparing good versus bad, old school, or disconnected supervisors. And according to paramedics, supervisor support pertaining to OSI included demonstrating value for the paramedics' health over key performance indicators. So example is granting downtime to diffuse when requested, as opposed to pushing them to do another call or prioritizing another call. Other forms of support included casual check-ins and follow-ups, and it's all done in non-invalidating, non-judgmental ways. However, whether paramedics would be supported or not depended on the supervisor. And supervisors also acknowledge the variability of support amongst their occupational cohort as well, as summarized by the following quote. I think in our supervisor group, there could be some tightening up of our training. There are inconsistencies in how supervisors are responding. Some of the contributors to these inconsistencies were due to a lack of systematic training and a lack of formalized procedures and policies to guide decision-making. Firstly, training in mental health or mental health first aid has not been mandatory for supervisors. And this limited training, combined with a lack of formalized policies and procedures, resulted in reliance on personal judgments, beliefs, and values on mental health. And this becomes particularly detrimental for any self-reported critical incidences or the more chronic and cumulative forms of OSI. I also want to point out that our supervisor interviewees had also mentioned that there's a lack of organizational support for their mental health. And this really underscores the need for top management commitment to address OSI at all levels of the organizations. So some implementation tips, there's a bunch, but I just wanted to really highlight one of them in today's talk, and that was to train and ensure supervisors feel comfortable in conducting wellness checks. And so I particularly say feel confident to conduct as opposed to have the knowledge to do it, because there are studies that are showing that managers' confidence as opposed to knowledge in their roles was the strongest predictor of behavior. So managers who felt confident discussing mental health were significantly more likely to make contact with employees with a suspected or to be suffering from a mental illness or was on a sickness leave due to mental health reasons. So the Provincial Health Services Authorities of British Columbia actually came out with a very comprehensive training course and resource guide for conducting a more employee psychosocial check-ins. And the guide goes over how to plan and prepare for a check-in, how to do a self-check before the check-in to ensure the capacity to remain non-judgmental and compassionate. And it also goes over the conversation arc of a wellness check. So how to set safe boundaries for both parties and initiate the conversation. Listening, so the 80-20 rule, 80% of the time is listening. And how to transition to either making a plan or planning a follow-up as well. So this was a really good resource that was shared with me with some of our research partners. All right. Oops. All right. So the next point was mental health training and awareness. And so for mental health training and awareness, all of our interviewees emphasize the importance of mental health training and awareness and its role in reducing stigma and creating the shared understanding of the general risk, signs and symptoms of OSI, and what are the healthy and unhealthy coping strategies. Our interviewees also shared that their organizations either offered or mandated basic mental health awareness training for paramedics, and that the peer support team received additional psychological first aid training as well. However, with the training, interviewees also noted that these training programs were often too general and theory-based, and this made it difficult to actually put into practice. One of our paramedic summarized this point by expressing, well, a course is great, but it's so generalized because it doesn't apply to you yourself. And although basic training has been provided to paramedics, our interviewees also noted that they would like for their loved ones and their mental health professionals to be equipped with the necessary information to effectively support them. So this often meant some form of occupational awareness and understanding of the paramedic culture and their working conditions. In terms of implementation tips, BC First Responders mentalhealth.com has developed a comprehensive list of desired knowledge, skills, and abilities for a variety of stakeholders to address OSI. They have specific criteria for senior leaders, supervisors and managers, paramedics, trainees and recruits, and the family members. And so they actually had this criteria, and they assessed multiple training programs against these criteria as well. So you know which program meets which of the knowledge, skills, and abilities. So that's a good resource out there. The training should also be provided at regular intervals during work hours, and the sessions should be kept short and tailored to the needs of each stakeholder group. For stakeholders outside of the workplace, supplying information packages may also be an option. Now, in addition to training, our paramedics and union representative interviewees, they noted that mental health training needs to be coupled with opportunities to apply it in the workplace, especially for recovery and maintaining resiliency. So paramedics identified that there are many organizational barriers that prevented its application. So things like the shift work, the on-call nature of the work, having limited rest breaks in high volume areas, and staffing shortages. So interviewees suggested that this creates a dilemma of acknowledging the need to rest and recovery during a shift, while not wanting to do a disservice that compromises the team's performance. And this was summarized by the following quote: "I don't think the organization allows them, the paramedics, to use it right now, because if they do use those programs, it's a negative pressure that's put on them. So if you don't come in and do overtime, you're making everybody else work harder. If you book off sick or fatigued, you're making everybody else work harder. So this really kind of reemphasizes the earlier point for supporting a psychologically healthy and safe work culture in supporting workers in engaging in daily practices that promote mental health and well-being. Because without these opportunities or without organizational support to apply the training can sometimes be perceived as an action item for the organization to complete or check off, rather than being perceived as a commitment to support paramedics' mental health and well-being. And so something that organizations can do to support workers in engaging in daily practices to maintain mental resilience is to allow downtime during a shift and ensure that workers can take vacations whenever possible. So these points really speak to having adequate staffing. So some other tips were to use staffing or scheduling strategies that match typical volumes and support consistent work cycles and team makeup. Organizations can also provide workers with specific training on coping strategies for shift work, work-life balance, and non-critical stressors as well, because a lot of the attention has been on dealing with the trauma aspect of the work. All right, so that is all for primary prevention. We'll move on to early detection and intervention. And these initiatives for early detection and intervention, they're aimed to identify and support individuals with early signs and symptoms of disease or injury, right? And these are very important in the context of OSI, because we know that they can be reversible or temporary with early intervention. And when we asked our interviewees about what's ideal for early detection and intervention, they said that having mechanisms in place to recognize the diverse signs, symptoms, and stressors of various OSIs was important. So not just focusing on PTSD and not just recognizing the critical calls, but also recognizing the cumulative and less traumatic stressors as well. In addition, they stressed the need for a variety of support initiatives to accommodate for individual preferences, because everyone copes differently. So for participants in this study, in our interviews, consistently reinforced the need for effective strategies to recognize potential risk factors, as well as signs and symptoms of OSI, to allow supervisors, peer supporters, and others to check in and offer support. And many interviewees shared that their organizations used a predefined list of critical incidents. So when one of these occurred, would automatically initiate a check-in. So here on the slide, I posted a list of the terrible 10, and that's from the International Critical Incident Stress Foundation. And this is just as an example, but it's best to customize this list to the needs of your organization. It's also important to note that this list does not account for unique individual triggers or non-traumatic, chronic, and cumulative stressors that also need organizational recognition and monitoring as well. Now, in terms of monitoring the signs and symptoms of OSI, organizations often have a formal incident reporting mechanism in place for self-reporting, but they're often underutilized. And many supervisors shared their personal practice of getting to know their staff informally and monitoring behavioral changes that way. And paramedics also suggested that friends and family, if equipped with the appropriate knowledge could help recognize signs and symptoms of OSI. Annual checkups with mental health professionals was another common suggestion. In terms of implementation tips, one is to ensure that the reporting process is straightforward and respects the worker's privacy. Ensure feedback on the creation of this list of incidents that would automatically initiate a check-in, and ensure that paramedics are aware of this list so that they're not surprised when they get a check-in call. And when we get to the other part of early detection and intervention, having that variety of support initiatives for OSI, all our interviewees emphasize the importance of having multiple types of mental health supports to accommodate paramedics' diverse coping strategies. And so paramedics explained, for some people, they want to be approached. They want to be asked, hey, let's take you off service and talk about it. For others, they want their downtime. Everyone deals with these differently, so it's hard to have one thing. So really, there's no one-size-fits-all solution in terms of these support initiatives. But one thing that was agreed upon, it was regardless of what they were, these supports needed to be readily accessible and responsive, similar to how the services that paramedics provide. And so some of the key forms of supports that were discussed were downtime or stress leaves, support from colleagues. So for example, the peer support program, or strategies to increase access to mental health services. So that those could be extended health benefits, the employee and family assistance program, having an in-house mental health professional, or a mental health referral network. So I won't go over into each of these support initiatives in detail, but these are documented in our reports that I can make available. That is available on our website. So from talking to the interviewees, though, most of these supports are available at their organization, but their accessibility, their implementation, and the effectiveness varied across organizations. All right, so disability management of OSI. So these are approaches aimed to support the recovery of paramedics during a work debilitating OSI, and when these injuries become manageable, their work reintegration. So for disability management, interviewees consistently suggested the need for communication during a medical leave and meaningful work accommodations. So for workers who have work debilitating OSI and are on medical leave, communication during the medical leave was a recurring topic of discussion. However, there was uncertainty as to how to execute it effectively. Most paramedic participants suggested that the lack of communication from their supervisors during a medical leave may create feelings of isolation or being forgotten. So one of our paramedic interviewees explained, so you give all these years to them and then you go off and you're struggling, and the company doesn't check in with you, doesn't acknowledge the good work that you've done, just kind of leaves you hanging. And so it was agreed that check-ins, although there was uncertainty about it, it was agreed that these check-ins should focus on the individual's health and recovery, and not on the legitimacy of their illness or when they could return to work. Now, from the supervisor's perspective, choosing not to follow up with employees was typically due to a concern of re-traumatizing the worker. So they would rarely make contact until it was time to discuss return to work. For some others, there might be a sense of distrust in the paramedics' illness or recovery process, questioning, are they abusing sick time, or is there really still a problem? And so these calls, these wellness check calls, these calls from the workplace, during the medical leave, they have to be built on a good foundation based on all the things we've talked about earlier for primary prevention and early detection and intervention. And one of our interviewees really summed up the existing gap right now. They said there is a need to establish a system where paramedics can trust in those phone calls. Right now, we don't have a good, trusting, healthy system where employers could do that easily. So make those phone calls easily. And so in terms of implementation tips, I again refer to that resource developed by the Provincial Health Services Authority of BC. And for our last point, finding meaningful work accommodations for disability management. From paramedics and union representatives' perspective, meaningful work accommodations was central for sustainable and successful return to work and stay at work. For paramedics who are ready to be reintegrated back into the front lines, there are many pre-established options to gradually build capacity towards working full shifts. So these included things like working day shifts only, avoiding peak times, being third on a car, working reduced hours, or having reduced shifts. But for paramedics who are not yet able or unable to return to the front lines, finding meaningful work was not always that straightforward. The readily available alternative duties were often administrative tasks, which paramedics did not find meaningful. So the following sentiment was shared amongst all interviewees. Sometimes they get put into these menial type of clerical tasks. They do not want that type of task and do not find it meaningful at all. And so some implementation tips were to work jointly with workers to identify the limitations and appropriate and meaningful modified or alternate work, and to monitor and adjust the accommodations as necessary, and follow up regularly with workers, even if they have resumed their full duties. Okay, so we've covered a lot of different initiatives for the desired organizational elements for the primary prevention, early detection and intervention, and disability management of OSI. And it may seem daunting, but many services actually have either considered or implemented many of the programs, policies, or practices in place already. So to close off, I want to say that although organizations have the interventions implemented for primary prevention, early detection and intervention, and disability management, which may make it seem like a comprehensive approach to addressing OSI, we did also identify some systemic challenges with coordination, resource allocation, and worker engagement to improve the effectiveness of the interventions. And these challenges were often attributed to resource constraints, such as staffing shortages or insufficient training or a lack of formalized procedures and policies. And these gaps can lead to feelings of distrust, isolation, and resentment amongst the paramedic staff, which can quickly spread throughout the organization and compromise the work culture. So ultimately, these challenges may prevent paramedic services from optimally addressing OSI in the workplace. So we believe that applying our findings into a broader organizational management system framework may help to ensure that resources are available and coordinated and effectively implemented. So management systems include additional elements that may be critical for addressing OSI in the workplace, such as top management and leadership commitment to improving psychological health and safety in the workplace, and performance measurement, monitoring, and continuous improvement. And so that's what we're trying to do. That's what we're doing. Some of the data that I've presented here today, they've now been included into the CSA Z1011.1 Paramedic Work Disability Management Standard. And so that standard is now available for public review with the given link, and that's open for review until June 27th, 2021. And you might also be asking, well, we're in the middle of a COVID-19 in the pandemic. Do these elements and initiatives apply during public health crises? And the answer is yes, but there's a lot more that can be enhanced with each of these elements during a pandemic or public health crises. So we have been working to develop a guideline to address OSIs during public health crises based on some of the elements I've talked about today. And that guideline will actually be out for review and feedback soon. And so this concludes my prepared presentation. If you're interested for more thorough analysis of the research expressed here today, I invite you to peruse through the reports listed in the slide. Also, if there are any specific programs that I mentioned in this presentation that you would like some more information on, I'm more than happy to share some of the resources that I have with you. So please don't hesitate to reach out. At this moment, I'd like to thank our funding source, the Defense Research and Development of Canada, DRDC, throughout the years for supporting our research projects. And I'd like to thank our research partners, Paramedics Chiefs of Canada, Paramedic Associations of Canada, CSA, County of Renfrew Paramedics, Peel Paramedics and their union, as well as Alberta Health Services. I'd also like to thank my colleagues, Dr. Marcus Young and Jennifer Gruber, and most importantly, the participants who have volunteered for these studies.
The recording of our webinars are available through our YouTube channel. Please subscribe and you can see all the recordings of our webinars. If you need the slide deck, please connect with Bronson Du, and he will be happy to share with you the slide deck. Next, please. At the end, again, I would like to thank Bronson for his time, and I would also like to thank our audience today for taking time to participate in this webinar and for your interest in our webinar series. Thank you so much and have a wonderful day.